السلام عليكم ورحمة الله وبركاته. أهلا وسهلا بالجميع. طبعا اليوم حيكون دورتنا مختلفة. حتكون بعنوان مقدمة في علاجيات الأطفال Introduction to Pediatric Pharmacotherapy. طبعا حيقدم لنا الدورة هذه الدكتور فارس رجب النفاعي. طبعا هو مشرف وحدة الصيدلة السريرية بمستشفى الأطفال بالطائف، صيدلي سريري مختص بالأمراض المعدية لدى الأطفال بمستشفى الأطفال بالطائف، مسؤول برنامج استخدام الأمثلة للمضادات الحيوية بمستشفى الأطفال بالطائف، حاصل على درجة البكالوريوس في صيدلة من جامعة أم القرى، حاصل على شهادة دكتور صيدلي من جامعة رياض العلم، حاصل على درجة الماجستير في صيدلة سريرية من جامعة رياض العلم. تفضل يا دكتور، المايك معك.
السلام عليكم.
السلام ورحمة الله وبركاته.
شكرا لك أستاذ طارق.
أهلا وسهلا.
طبعا في البداية أحب أشكر إدارة التدريب بصحة الطائف وإدارة مستشفى الأطفال بالطائف، ممثلة بإدارة التدريب وقسم الخدمات الصيدلانية، وأتمنى لكم حياكم الله جميعا. أتمنى لكم وقت إن شاء الله ممتع ومفيد.
ممكن تعمل شيء. أيوة تمام.
طيب بسم الله. So our topic today will talk inshallah about pediatric pharmacotherapy and a brief introduction. Our outlines will be a brief introduction to pediatric and their differences in age groups. Then we will talk about pediatric pharmacokinetics specific for this population. Also medication safety in pediatric and how we overcome medication or minimize medication errors. And lastly, the communication skill with pediatric population. So first, I would emphasize on this statement, which pediatric patients are not little adults. And this lecture will be explaining this specific statement. Pediatric pharmacy, first of all, is a practice who focus on providing recommendation for age-specific and pediatric patient regarding the most effective and safe drug therapy. And this practice have been recognized and supported by many international organizations like American Society of Health System Pharmacists and other organizations. So our population is unique in Saudi Arabia. Why? Because 30% of Saudi are under 15 years, which makes a huge challenge for us to communicate and supplement the proper medication to this population. Also, this population are different in comparing them with the adult in pharmacokinetics, pharmacodynamics, and how to select medication, and also the management and treatments options. This differences is according to the developmental changes in this age group. And also the patient and the caregiver should be involved in the treatment plan. So in this study of the US, 14% of children have ever been diagnosed with asthma. This is a question for do we have patient that taking chronic medication? Yes, we have. This study is proposing that 14% of US children have been diagnosed with asthma. 8% of them have learning disabilities, and also over 10 million children are taking medication or have had been taking medication for at least 3 months. The challenge that we are dealing with in pediatric, that approximately 75% of current medication lack the dosing, efficacy, and safety data in pediatric. So classification of pediatric patients are important because it is depend on the age when we are selecting medication for a specific age group. Also, some medication are contraindicated in some age group pediatric patient. So for patients from birth until 4 weeks, we call them neonates. And from 28 days to 12 months are infant, and children from 1 year to 12 years. Growth and development also very important to detect in pediatric, because many nutritional supplement are depending on the development and growth changes in pediatric. So this chart, as we can see here, is specific for Saudi children. Have been designed by our scientists in Saudi Arabia, that is explaining the growth of boys from birth to 60 months, and we can track the developmental and growth changes according to the weight and age of each patient, and can we calculate the percentile that this patient is following, and we can know if the patient is under or over development or growth. And this also is a height for age percentile. So we have different markers to detect growth and development in pediatric, which is height, age, length or height, and head circumference. And every gender has a different chart to calculate the percentile of the patient. And for example, this one is for girls from birth until 60 months, when we are detecting the weight for age percentile. As I said before, it is a Saudi specific chart. And this one is for height for age percentile in girls. So another thing is the vital signs. We are dealing with many age groups that have many differences in according to their vital signs, and the normal ranges that is specified for this age group. Normal heart rate and respiratory rate are increasing, decreasing with age, whereas blood pressure increases. Of note here that blood pressure, it's not only age dependent, but also sex and height percentile dependent. and the reference ranges is different according to the resources that you are taking from, which is important to implement one protocols that is applicable in your institution. So, for example, heart rate in neonate and infant that can reach up to 205 beats per minute, which is considered in adult that is a heart disease. So we need to know the importance of the normal ranges according to the age of our patient. As we can see here, 3 months old pediatric patient until 2 years, they may reach up to 190 beats per minute. And also for respiratory rate, infant may have increased the respiratory rate and reached up to 60 breaths per minute. And this one is decreasing as we go in the age until we reach school age children with 18 to 30 breaths per minute. So as well as laboratory values are very hard to recall the normal ranges of laboratory values with different age group, because it is an age specified and age dependent. So every age group has different values, but the technology has made it easy for us to spot the abnormalities according to patient age. And one of the excellent resources that we are using is the Harriet Lane handbook, specifically for laboratory values and medication dosing. Another thing is important when dealing with pediatric patient, that is calculation. So calculations is important in dosing the patient. We are sometimes using body mass index for dosing, or body surface area and ideal body weight. And also creatinine clearance, we have a different equation from adult patient in calculating creatinine clearance. We are using Schwartz equation that is specified for pediatric patient, and there is a constant that is specified for every age group. Another equation that we are honestly don't normally use is dosing of unavailable data of medication for pediatric. So if we have a medication that we do not know how we should give a pediatric patient, but we have the dosing for adult, we can use this equation. But nowadays we have many resources that is doing this calculation for us, and we can depend on their calculation. And another section is pediatric pharmacokinetics. So pediatric have different pharmacokinetics from adult in every stage of the pharmacokinetics, in absorption, distribution, metabolism, and elimination. There is some pediatric specific factor that may alter the pharmacokinetic of the medication. Let's talk about absorption at first. Absorption are altered by age, so it is age dependent for each age group of our population. So the first barrier we are facing in pediatric patient is drug rejection. So the patient or the child may reject the drug in many ways, and this is very difficult, and we have different and various strategies to overcome this problem. Also, gastric pH production is low in pediatric, which may raise or gastric acid production is low, and that may increase the pH of gastric. And it reaches the adult values at age of 3 years. So also another factors that may affect the absorption of medication is drug formulation. We have no specific drug formulation for our population, and we have different concentration, and we sometimes depend on the formulation that are taken by adults, like capsules and tablet. Also, as we mentioned before, the patient rejection, and patient may reject as for smell, for example, texture of the medication, the appearance of the medication. If they don't like the medication, it is very hard to give the patient the dose. And also the gastric emptying time is prolonged in newborn and infant patient, and this may alter the bioavailability of medication. Normal flora as well production is low in pediatric patient. We have also the absorption of intramuscular injection, and we have specific pediatric factors that may alter the absorption of medication given intramuscularly. The most common one is muscle mass. In pediatric, we have low muscle mass, and we have specific volume according to the age and the weight of the patient. And another one that may, and this will increase the absorption of our medication. And also another one is capillary density. Capillary density is high in pediatric patient, and that may increase the absorption of medications. We have a volume specific for medication that given intramuscularly, we cannot exceed this limit in volumes according to the weight of the patient. So up to 2.5 kilogram we can give as a max volume per ml is a half ml of our medication. We cannot exceed that. And for patient weight 4 to 12 kilogram, we are allowed to give 1 to 1.5 ml of our medication as intramuscularly. So another route of administration we have here is percutaneous. So our population have a thinner skin and weaker skin. That means we have a limitation for medication that can be given percutaneously and volume of this medication. Also, another factor that may affect the absorption of medication that given percutaneously is a high perfusion, which may increase or decrease the absorption of our medication. Also, we have a body surface area weight ratio that is very high in neonate children population, and that may or may not increase toxicity of medication, especially topical medication. Distribution, we know that pediatric patient has a more percentage of body water comparing with adults. So if we have a preterm patient that has 92% of their total body is water, comparing to adult is only 60%. Term neonate has a very high as well total body water with 75%, and this will affect the distribution of water soluble medication, and we may need to give more doses of our water soluble medication. So a high percent of body water will affect drug distribution and subsequently plasma concentration. For example, here aminoglycoside, we have to give a high concentration of aminoglycoside to reach the MIC of the medication that can kill the organism. A low body fat is responsible for increased plasma level of lipophilic drugs. As we know, lipophilic drugs are stored in lipid, and in pediatric patients we have low body fat, and that means the lipophilic drugs will be freely in the plasma. And another factor that is plasma protein binding of medication. And pediatric patients are account for the free drug in plasma, especially for high binding protein medication. Another factor is drug transporters, like PEG lipoprotein. We in pediatric have low tissue expression of this drug transporter. The metabolism of medication in pediatric has also age-specific factor that may alter the metabolism. Drug metabolizing enzyme, mainly CYP enzyme, in pediatric has high activity in infant and children for some of them, like CYP3A7, whereas CYP1A2 has reduced activity and birth, and this metabolizer is affecting the concentration of and free drug available in the plasma. Glucourination is reduced in neonate and infant, and especially these drug metabolizer are responsible for some specific drug adverse effect that we are facing in pediatric population. The last element of pharmacokinetics is elimination. Elimination mainly done by kidney, and in pediatric we are we are not fully functioning in neonate. The kidney are not fully function in neonate. And also the kidney is receiving only 5% of cardiac output comparing to 50% in adult. The renal blood flow as well is low at birth, and also calculation creatinine clearance using Schwarz equation. So we here going to look at pediatric specific adverse drug reaction, and one of the most common pediatric adverse drug reaction is when using ceftriaxone in neonate patients. That we are facing a disease called kernicterus, which means displaced bilirubin from protein binding. That is the effect of ceftriaxone. So the recommendation is avoiding the use of ceftriaxone in high-risk jaundice infant. Another medication are fluoroquinolones. Fluoroquinolones are known to cause lesions of the cartilage, permanent lesions. That is irreversible, and this is why we reserve fluoroquinolone as a last line in pediatric patients. Another medication is chloramphenicol. Chloramphenicol is causing gray baby syndrome in pediatric patients. That is caused by increased its bioavailability due to immature UGT metabolism. And our recommendation is always avoid and do not use chloramphenicol in neonates and infant. Another famous medication that can cause a specific adverse drug reaction is aspirin, which can cause a disease called Reye syndrome. And our recommendation is to avoid use as antibiotics. And they find that aspirin, when using as antibiotic after a viral infection, that may cause this syndrome. Let's take a look about medication safety. So we have a standardized definition of medication errors, that is any preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in the control of the healthcare professionals, patient, or consumer. Such event may be related to professional practice, healthcare products, procedures, and system, including prescribing, ordering, communication, product labeling, packaging, and nomenclature, compounding, dispensing, distribution, administration, education, monitoring, and use. This is for all adults and pediatric, this definition. But we will focus here in pediatric and how we overcome the common medication errors in pediatric population. As we can see here, pediatric patients are at high risk of medication error than adults, and the rate of medication error is 50% of medication ordering. The vast majority of these errors happen during ordering. And the most common classes of medication is antibiotic, analgesics, and electrolyte. Medication errors are most likely to cause harm in pediatric than in adults. So what are the risk factors of medication errors in pediatric patients. First, we have a high volume of distribution. This may cause harm and in some medication, and it may cause low effect of others. Low protein binding of high binding protein, if the like valborate that has high binding protein. If we have low protein in our circulation, that means we have high concentration of a freely fraction of medication. Another factor is we always use weight-based dosing in pediatric patients, and some error may occur when writing the dose of the medication with 0.5 without recording the 0 before. Off-label of use of medication. We in pediatric use off-label use of medication frequently. Communication barriers with the patient and the caregiver. Another factor is lack of standardized dosage form. So drug formulations suitable for children are mostly unavailable. We do not have it. And we need to encourage the manufacturer to do a standardized dosage form. Extemporaneously preparation of oral suspension can lead to alteration of drug bioavailability, and that we are always using tablet and capsule for preparing oral suspension or solution in pediatric patient, and this may alter the stability of the medication and increase the risk of harm. Another strategy that we are using, which is extremely wrong, that emptying capsule and crushing tablet, and may cause a serious harm for patients. Another factor that is drug commercially available with multiple concentration. What does that mean? That means we have a multiple concentration according to age group for specific drug. For example, amoxicillin and clavulanic acid, we have different concentration. And when we received a prescription of augmentin that is written ml, written in ml instead of milligram per kg, and stating the concentration of the preparation, that may cause a medication error. Also, the difference in age and weight, and to meet the need of a small infant. And error also may happen when wrong concentration is used. How can we prevent or minimize medication error in pediatric? We have different strategies. First of all, in addition to standardized medication error preventive strategy, we encouraging manufacturer to standardize medication formulation. Weighing, this is a very important thing. Every patient that is admitted has to be weighed and recorded in the medical record. Also, the weight should be always in kilograms, and also use oral syringes to administer oral medication instead of telling the patient to take a 1 teaspoon or a half teaspoon. Another strategy is patient-centered care. We need to focus on the patient for minimizing medication error, which can be done by age and weight-based dosing. When prescriber is dosing the patient, they have to record the age and the weight and the base of the dosing on the age and the weight. And do not hesitate to verify the order if you are a nurse or pharmacist from the prescriber. Dispense medication in pre-measured form like oral syringes and unit doses dispenser. Consult the patient and their caregiver. The last section, we are talking about communicating with children and caregiver. Communicating with patient and their caregiver is an important component for assuring medication adherence, patient safety, improving outcome, and patient satisfaction. And when communicating with pediatric patient, we need to consider age differences and age-specific approach. And some of this age-specific is mentioned in this slide. And when we are communicating with an infant patient, it is not possible to deliver medication education to infant. However, it is very important when you are interacting or communicating with patient's infant, the patient or infant has to be calm. And another thing, do not approach to infant if they are anxious. That will make it worse. And do not take them from their parents. Also, give parents time to calm their infant. When we are dealing with preschooler, preschooler, we mean a child aged from 1 to 5 years. At this age, children do not understand the importance of medication education. And also they do not care of listening to others. And the key element of communicating and interacting with preschooler is patience. Also avoid asking questions with a prolonged answer, because at this age, pediatric patients may prolong the answer to your specific question. Also, deliver information in a very simple way. Another age group is school-aged children, and we are talking about 5 to 12 years age. At this age, children are more accurate at recalling information. They are more accurate than their parents themselves. So try to take their note very carefully. And also they have a huge interest in medication information. They want to know what they are taking. They want to know how to take the medication. And they can report any side effect or any symptoms after taking this medication accurately. Give them time to ask whatever they want to know. Also contribute them in decision-making process. We have a general recommendation for all age group or pediatric patient when communicating with them and their caregiver. First, sit at or below their eye level. Also start with a smile. Talk about something they are interested in. Be aware of their body language. If they don't want to talk, don't force them to talk, and give them your full attention. And they want to know if you are understanding what they are telling you. So repeat after you heard from them. Also speak in normal tone of voice. Show interest to them. Take the time to answer question and address concern. Also involve the child in the conversation. If they are, if they can talk, obviously. A take-home point, I cannot emphasize more on this statement. Pediatric patients are not small adults. They make their own unique population, and they make their own pharmacokinetics, the developmental changes they are facing that may affect the pharmacokinetics and pharmacodynamics of medication. And also always use specific age weight based dosing. This is a very important one. And communication is the key for best practice. Communication with pediatric patients, communication with caregiver, communication with other health care professional is a key for best practice. Thank you so much.
Thank you very much for informative lecture. الله يعطيك الصحة والعافية دكتور.
الله يعافيك. الله يسعدك.
بارك الله فيك. طيب نستقبل الأسئلة. If you have any questions or any ad, please just write your question in the Q&A. اللي عنده أي سؤال أو استفسار ممكن نروح على خانة Q&A ويكتب السؤال للدكتور فارس. مش في الشات. اللي عنده أي سؤال ممكن يتوجه لخانة Q&A. تمام. طيب الظاهر دكتور فارس إنه ما عنده أي سؤال. شكرا ما شاء الله تبارك الله.
الله يعطيكم العافية.
الله يبارك يعطيك الصحة والعافية. بارك الله فيك.
شكرا.
طيب دكتور شكرا لك. بس بشوف إذا كان الأستاذ عمر موجود معنا. طيب الله يعطيك الصحة والعافية. بارك الله فيك. شكرا لك دكتور فارس. هذه شهادة شكر مقدمة من إدارة الشؤون الأكاديمية والتدريب عشان بمناسبة مشاركتك معنا في زوم اليوم في منصة إرادة. إن شاء الله ما حتكون آخر مشاركة. إن شاء الله نشوفك إن شاء الله في مشاركات قريبة بإذن الرحمن. الله يعطيك الصحة والعافية.
شكرا لكم.
بارك الله فيك. طبعا اليوم بدأ في الصباح اللي هو اليوم الأسبوع العالمي لمكافحة العدوى، وانتهت أول ورشة عمل في الصباح اليوم، كانت من الساعة 9 للساعة 12 مساء. استكمالا لهذه الندوة طبعا بكرة إن شاء الله حنستضيف تحت رعاية مدير الشؤون الصحية وكذلك مدير برنامج مستشفى مقدمة التخصصي. حنكمل الندوة تحديات الموجة الثانية لفيروس كورونا كوفيد 19 بين المنشآت الصحية والمجتمع. حنستضيف فيها وكيل وزارة المساعد للصحة الوقائية الدكتور عبد الله عسير، حيكون موجود معنا إن شاء الله من الساعة 7:30 للساعة 9:30، وكذلك الدكتور نزار بهبري استشاري أمراض المعدية بمستشفى فقيه بجدة. فانتظرونا إن شاء الله. يعطيكم الصحة والعافية. طبعا اليوم نحن بثينا تقريبا 45 دقيقة. حنشوف إن شاء الله كيف لازم الحضور لازم يكون بنسبة 92% من نسبة الحضور لزملائنا وضيوفنا من خارج المنصة. بالنسبة لزملائنا من المنصة إن شاء الله حيلاقوا شهاداتهم في قائمة شهاداتي غدا صباحا بإذن الرحمن. بالنسبة اللي خارج المنصة إن شاء الله حنشوف القائمة اللي هي زي القائمة هذه، الاسم، الإيميل، وحنشوف عدد الدقائق اللي حضرتوها. إن شاء الله حنشوف كيف حنرتب الأمور ونحسب 92% من عدد دقائق الدورة اليوم. شكرا لكم جميعا، وإن شاء الله نلتقيكم على خير، في أمان الله.